Hey, good afternoon, everyone. I'll be presenting on the mass drug administration here in Fiji in terms of the Tamanu Database. Just a brief about the program before I jump straight to the that database that we are currently using with Tamanu. Lymphatic Filariasis Program has been running in Fiji for more than 20 years. And it's a program that that falls under neglected tropical disease under WHO, and WHO has been trying to eliminate this not only in Fiji but the other countries. And in the past years, 6.7 billion treatment has been delivered from 2000 to 2016. 499 million people no longer require the treatment in some countries. And in terms of the financial, there has been 100 billion US dollar that has been utilized in terms of trying to eliminate lymphatic filariasis in all areas, in all parts of the countries. Fiji, when WHO started with the elimination of lymphatic filariasis, they created a Pacific elimination Pacific elimination of lymphatic filariasis, and this is where Fiji joined in year 1999 in terms of working towards eliminating it as a public health problem here in Fiji. Just in terms of the program and how it operates, it consists of this entity that works together to help in the elimination. We have WHO, in which our program, the lymphatic filariasis, align its guidelines towards in terms of elimination. We have JICA as well that support the program, and we have and we also align ourselves to the Global Alliance of Elimination, and the target is to eliminate it by year 2030. And this is following the neglected tropical disease roadmap. And in order for us to eliminate it, we need to have this prevalence of less than 1%. And we have the Ministry of Health as an arm in terms of delivering this activity in terms of elimination and implementing the activity. And we are based at Fiji CDC within the Ministry of Health, and we fall under the Health Protection Program within the Ministry. We work in terms of, there's the two guidelines that the criteria that we work in terms of eliminating, and the first one is, which is our main activity, which is to stop the spread of infection through the mass drug administration. And in order for us to eliminate in Fiji, the country needs to meet the validation criteria if 100% of endemic area pass final task. So in Fiji, they need to pass 3 TAS is a transmission assessment survey. They need to pass these 3 transmission assessment survey in order for us to say that we no longer needed the mass drug administration in the country. And the second criteria, the pillar that the program follows, is in terms of the morbidity management disability prevention program. And this is in terms of treating those who are already suffering with the disease. So this is in terms of our lymphedema cases and hydrocele. And one thing you know about this disease, it leads to body disfiguring, and this is where our morbidity program is responsible in terms of looking after them and providing the treatment that they needed. So in terms of just the prevalence, I'm sorry, I'm just going to go through with the lymphatic filariasis program so that you can understand before how, in order for us to, before we talk into the Tamanu database. So in terms of our prevalence, so like I mentioned earlier, we need to eliminate it by 2030 with the prevalence of less than 1%. So when we joined the Pacific elimination in 1999, we conducted a baseline survey and we had a 16.6 prevalence. And after a couple of rounds of mass drug administration, treating the community with the 3 drugs, that is albendazole, DEC, and ivermectin, we had come down to 9.5%. It decreased on the prevalence to 9.5%. And then in 2010, we started the program in terms of implementing in a national level. So that means everyone in Fiji are taking the medication in one go. But in 2010, it split into a divisional target strategy where Northern, Western, Eastern had their different treatment according to the cluster of the positive case that is present within the divisions. So that means only some divisions will be doing conducting mass drug administration, while the others will be just conducting surveys. And also, this is one way because mass drug administration is quite expensive activity to roll out. So this was a bit more financial, a cost-effective method in terms of targeting, in terms of divisionals. So this is just a prevalence status of what we can for the lymphatic filariasis. Bear in mind, the division that has more than 1%, these are our main target where we'll be conducting mass drug administration. So this is where the Tamanu database will be at most useful when we're rolling out mass drug administration. As you can see within the Northern, within the divisions, we have Westerns that are less than 1%. So that's the reason why we're not conducting any mass drug administration in the Western division. But we have a small hotspot island, which we are currently doing MDA in it, and that is in Maloro. In Central, the whole Central division has low, less than 1%. So we're not conducting MDA in the Central, but we're having their hotspot island, which is Serua Island, that are doing MDA. And we have Northern and Eastern, and all this Northern and Eastern, and the hotspot is the kind of site that we are doing MDA in which we are using the Tamanu database. Just a brief of we're working towards. So our program is working towards the elimination by year 2030. And this is to cover both the criteria that I've talked about, which is the mass drug administration, at the same time providing all the treatment that is needed with the mobility program. So the mass drug administration, where we are using the Tamanu database. So in terms of our mass drug administration, this involves the health workers going to house, giving medication to all the individual, either whether they have the symptoms or not. So this is just like a sensor where they go from house to house and taking their information. We actually do this for mass drug administration. We are the areas that are high prevalence. We conduct mass drug administration where each family needs to take the medication. And we usually conduct this in terms of the direct observation. So the health workers needs to be there and observe the individual to take their medication. This is the only way that we can eliminate it within the communities. So in terms of our recording, our data, so where we get the information. So when we started more than 20 years, we've always used booklet, our manual data entry. So these are information that we captured when they give medication, to individual households. We take their name, their address, the ages, the area that they've been implemented, the MDA, the number of medication, ethnicity, and all that. These are what the nurses recorded in their booklet. So in terms of data entry, so once they complete this MDA booklet, we get all this booklet and then we do manual entry. And this has been a practice for more than 20 years. And we're happy now that we have, we've got a database that we will exploit, and it's actually functioning within the Lymphatic Filariasis Program. There's room for improvement, but it's, it's a start somewhere. And so this is what we want to put into the Tamanu database. And this is what that helps us in terms of creating a database, or MDA form in the Tamanu base and Tamanu database. So all the information from the booklet are manually entered by the Lymphatic Filariasis Program. So bear in mind, when we're targeting all this division, these are big population, we're talking about more than 20,000, and then it will be entered by 4 program officers, which takes a lot of time. And in terms of getting coverage report, it kind of slows the program down in getting the information needed in terms of MDA coverage. And so far during our past years, we usually have 2 reports, which is the summary coverage report. This is just what they gathered from the booklet in terms of visually counting. And then we have the final MDA coverage report. This is when they actually enter every information in the booklet into the Excel, and then we do the analysis to get the coverage in terms of medical area, age, sex, and ethnicity, exclusion, and other information that we needed to report. So some of the challenges encountered when we're doing manual entry, like I said, we have limited human resources to conduct all this manual entry. Timeline of completion for this data entry usually takes 3 to 5 months, resulting in the delay in our coverage reporting. So we have to wait for the officers to complete all this data entry, and then we can actually report it on whether it was a successful coverage that was targeted, whether we have to conduct follow-up. And also in terms of other challenges is when we do data entry, this is upon return of booklet. So that means after the MDA is conducted. So when we're doing data entry, there's usually information missing. So we have to follow it back up. And because of some areas are, we are separated by oceans, it's sometimes the network is a challenge in terms of contacting the nurses back in following up in terms of clarifying the information that is provided in the booklet. So due to the challenges encountered with the delay in disseminating final MDA coverage, we were in a process of implementing Northern Division Mass Track Administration, and it was supposed to be scheduled in October to December. It was implemented in October to December to the last year, so this is just recently. And it was an integration with Vinaisi Bechu program when we roll out the Mass Track Administration. And upon discussing the challenges encountered, we started to explore some online database. And at first we had an option with the Red Cap, and then we saw how, and then we also saw Tamanu through COVID-19, and we saw that during COVID-19 vaccination was going, they were receiving coverage, and that was something that we wanted as well as a program level, while they distributing medicine, we're also getting real-time coverage. And that was when we decided to explore Tamanu, and we were happy that we were able to get some context, which they scheduled a few meetings. And upon discussion, we were happy with what they were offering. So we decided to use Tamanu. In that, WHO was on board as well. In terms of the financial support in MDA Tamanu Database. And we also had JICA that funded the tablets in terms of rolling out this MDA database. Just a few things that I wanted to highlight. This one of the things that I was happy with Dr. Michael's presentation. A few things that we encountered during this MDA was that we already had the planning going. So we had the booklet already printed and everything. And then when the Tamanu came in, there was a bit of challenges trying to link the booklet information into the Tamanu database. And Tamanu was a bit more, like I said, there was information that was provided was more helpful for us in terms of getting the consent that is needed, other important information. But for booklet, as you can see, our booklet is a bit congested, the information. We can't capture all the information in the booklet. So some of the information that were in the booklet, we had to just, summarize it and provide, ask for only a few things. So, but with Tamanu, we could have asked additional information that would help us in terms of following up. So it was a bit challenging trying to get the Tamanu to match the booklet, but at the same time, also including some of the information that we needed that was not in the booklet. But we were glad that the team that was on board, they were able, with the Beyond Center, they were able to capture as much information that we needed in the Tamanu. And this is what it looked like in terms of the MD recording booklet. So basically what was in the booklet, they put it in terms of the form which the nurses were going to use upon MDA. And yeah, this was, we had a couple of discussion upon this, how to finalize it. And we also had to pilot it before we actually roll out. And the concept of this is when they enter from whatever household or whatever zone that they're conducting MDA, we would able to view it from the Fiji Center for Disease Control upon if they sync the data that they have entered. And also one of the advantages is because we cannot stop population movement, and if you're dosing some individual, we had a component that we have to have a dose to. So in terms of keeping track where they are, so upon the dose two, when they search the information on the Tamanu, we can actually see whether they were already dosed. And this was helpful information for us. And for booklet, we couldn't do that because in booklet, we don't have the context. And so we just have to follow up with the drug distributor, the nurses. But with the Tamanu, that has enabled to give us that accessibility in terms of seeing if they were already being taking the medications. We also had an opportunity to do the Tupaya visual in terms of seeing the coverage-wise. And there was some issue with the Tupaya in terms of getting the exact details, geographic-wise, of especially when Fiji has a lot of islands, and getting that into the Tupaya visual. But yeah, we were able to sort that through with the team that was engaged with the Lymphatic Filariasis Program. So this was some of the information that we could view in terms of the number of doses that was taken, the number of those two, in terms of the dates that the MDA was taking place, the exclusions, the gender, all these, it was like provided to us with just the click of the option where you can just view it instead of me waiting for the data entry officers to complete the data entry and then me analyzing everything. So this was a big help for us in terms of the analysis component, and it was something that we were happy with in terms of the biovisuals. So when we started with the planning with the Tamanu database, we had a Malolo MDA that was coming, and we decided to pilot it before it was a live. The live version was rolled out in a bigger setting, which is Northern Division. And we were happy that Beyond Essential staff was there with us. You know, if you have an actual staff there, you would actually know what the process is involved on ground level. So it was a big help there when the Beyond Essential team that joined us. We had someone that was doing medication. We had a booklet and being done at the same time, booklet entry and Tamanu. Because we were first-time users, we were a bit worried because we didn't know what Tamanu database got to offer and how it will look in terms of in the field. We didn't want to risk losing out information in terms of if there's you know, the data or the database kind of like play of the tablet. So we had conducted both. We did booklet entry and someone was with the booklet officers that were doing booklet entry, and they were also doing Tamanu entry. And this is just to ensure that we do not miss out any information if somehow the app kind of broke up. Not everything is broken up. But yeah, that was what we had done. So, but it was good, but at the same time, it was a bit challenging because it was a duplication of workload. We're entering the same information, and it requires a lot of human resources. We need additional officers to do data entry while the nurses is doing entering the MDA booklet or in other offices. So this was out of what we got from the pilot Tamanu. We were able to instantly have the full report upon completion of Malolo, which was great rather than for us waiting for the data entry to complete it. Also having a staff there able to identify some of the hiccups that was present in the database before we actually roll out to the Northern Division, Tamanu, which was a bigger population size. In terms of our Northern Division, this was rolled out and launched in 28 September. It was launched because we had integrated MDA and also because it was the first time for us to also use the Tamanu database. And after the launching, we rolled it out in between October to December last year. And as you can see, we have the officers doing data entry, we have booklet entry, and the medication are being given out in the community. We also had a chance to do follow-ups because on the pilot, we realized there was a lot of amendments, so we got to solve it. But then the real picture comes in when we actually roll it out in the live field. And like Dr. Michael had said earlier, this is when we actually saw a lot of hurdles in the MDA. So we had some of the challenges we encountered. There was bugs where we were slowing down the app. This is result in nurses wanting to go back to their normal data entry. Some of them, their morale were like, okay, we just leave the data entry, we just continue, and then we'll come back and do the data entry. And this has created a bit much job for us because the more they leave the data behind, manual data entry, the more they create backlogs. And this was some of the issues. Some of the other challenges, the nurses, this is running for more than 20 years. So some of the nurses were just used to the data entry and adapting to new technology and the changes. It was a bit challenging for them. And also because some of their bad experience with COVID-19 vaccination, and because of the lengthy process, they thought it would be the same thing with the MDA. So some of their mentality was like, no, we're not accepting this. We just wanted the manual entry and we can do the data entry later. And that was some of the challenges. So we had to come back to the MDA, and we had officers within the program coming to follow up and trying to rectify the problem in the site so that we can get the data that we needed. As you can see, this is the MDA coverage. This is the coverage in terms of what we receive from the subdivisional nursing manager, and that is the coverage in the two-pie visually. And as you can see, there's a big difference in terms of what was created, what was present there. And right now, and the main reason for this is the backlog of data. So upon the data entry, when they started to have a problem with their data entry or the Tamanu app, they started to leave the data entry and went with the manual booklet entry. And then that created a lot of backlog. And that is a challenge that we're currently having, where we now have to re-enter all the information so that we have a bit of a same correspondent as what we have received from the subdivision nursing manager. So that is something that we're working towards, and we hope in the next MDA we can rectify some of these challenges so that we do not create more job for us when we are hoping that the money will solve all that problem. So like I said, some of the challenges that encountered was the limited tablets. So when JICA had came on board to support the program, they were only able to provide 70 tablets, and Northern Division is quite a big divisions. And so that means we were going to only engage 60 users, like in one zone, there was going to be one tablet, but in Northern Division in the field, in one zone has more than 5 or 4 health workers that are responsible for each settlement or catchment area. So that means one tablet is being shared with 5 officers. And that was also one of the reasons that contributed to the backlog of data, because we had limited tablets on the ground. We also had a problem with terms of searching name with no space. And we started, we had to, people are like, we're so used to it. Type the first name and the second name, there's a space that is needed to be but when we started with the MDA Tamanu, they were not allowing us to have that space. You have to type the first name and the second name. But upon upgrades of the app, we were able to sort that out during the mass track administration. and also syncing data in a no network area. I know that Tamanu works in in a no network area, but in order for us to sync it, we need to have internet. And so some of these areas that they were using tablet, they have no network, and for them to sync their data, they have to travel a few kilometers to a network area to sync their data, and that became a challenge for them. So some of them just left the syncing and they just went on with data entry and then syncing it later on after a few weeks. But that becomes a problem because if something clears up with a tablet, you won't capture all the information because you might miss out some of the information that is needed. Duplication of workload, the limited human resource. Like I said, we were doing both booklet and Tamanu entry. Some of the nurses were already only 1 or 2 staff that was there. So if they didn't have officers that would help them to do the data entry, so they just resorted to giving medication and doing manual data entry, unless if there's another officer that are available that will help them to do with the data entry as well. And like I said, this is created to a lot of our backlog, which is why there's a discrepancy in the information shown in the supplier and what we receive from the nurses. So we were able to engage this with the Eastern Division MDA as well. So with Eastern Division, Eastern Division were only able to select Levuka, one of the islands, because in the Eastern Division, most of these islands are in our Lao group, very far, with limited accessibility to the islands. So their network is not as strong as the one in the Central Division. So we were only able to implement it in a certain site that had the network, and Levuka is where the receptor there. The rest of the islands, these are all Eastern Division, the ones on the left corner. And because the boat accessibility is the boat there is 2 times in a month. So it was a challenge for us to get all the tablet across and conduct training. But when the network is, there's not much as a good network that able for them to sync their data across to us. So this is the same, some of the challenges as well. It's a bit similar to the Northern limited network in the remote areas, because most of our Eastern Division are remote area settings. And we also had some shortage of nurses at the time that we roll out the Eastern Division MDA, and we had multiple programs that was already running on the ground. So that was not able to assist in terms of doing data entry with the MDA. So they only had to, the main priority for them was to roll out the MDA in terms of giving them treatment, and the data entry was the same case where they have to do the backlog data entry. So way forward, I guess, for like mentioned earlier, for any projects, for any program, it requires a lot of funding. Tablet is quite expensive. So for us, for the program, because we only had limited, that had resulted in limited data entry from the field. So I think for way forward, our next MDA is, getting the financial support that's needed to purchase more tablets so that users could use it in the ground. Recruiting data officers, this is some of the requests that was from the health offices to have a specific data officer available with the nurses to do the data entry for them. And also we're hoping that we'll move away from manual booklet entry so that does not complicate and create a lot of data entry for the program ourselves. Providing resources in areas where there's no network. So if there's no network area, I think in terms of financial wise, is to support the health workers in providing transportation assistance so that they can get the data synced so that we can capture the information that we needed, and providing refresher training or workshop for nurses. Like I said, most of these nurses are used to the manual data entry component. So, getting them to train a workshop so that they can change their mindset will be something that will contribute towards them adjusting well with the use of MDA database, Tamanu MDA database. we were able to expand the use of Tamanu, not only on MDA, we also able to conduct transmission assessment survey, where we test the children, year 6 and 7, for cases for LF prevalence in the community, and we were able to have to use the Tamanu form. This was an advantage, and we were able to successfully roll it out in our central transmission assessment survey. There were just few issues with the Tamanu form, but it's something that we could fix, and we work towards and improving along the way. Sentinel survey is currently what we are doing in the community-based survey, and that's something we haven't rolled it out in terms of Tamanu, but we're hoping to schedule in the coming month and also use Tamanu on it as well. So in terms of the achievement, this is actually the first for Lymphatic Filariasis Program to have an actual database after more than 20 years of running. So we were happy that we were able to get that running, and it's also first in the Pacific region. Like I said, when we started exploring the database, there were no other countries that was using any sort of database. So we're happy that this could be a starting point for other countries in the Pacific that like to explore MDA as well in terms of database. So we were happy that we were able to create a database for the lymphatic filariasis, especially when it was something that we were working towards more than 20 years of just doing data entry, and it has worked well with us in this last 2 years and the last few months. Just like I said, it's a work in progress. As first time users, there's always challenges, hiccup, but we're looking forward to maintaining and sustaining this program so that we can work towards elimination in the year 2030. So just an acknowledgement, I guess I would just like to thank the central team. They were great in terms of explaining and then getting it into the database. Is not something easy, the processes, but they were very understanding despite multiple amendments. But we were happy that they were able to come on board, even in joining us in the field to see how the processes were involved, and also World Health Organization in terms of financially supporting in terms of the creating the database. I mean, like funding the database, and our JICA component, and the Worst Cannabis Program that also assisted in when we did integration, the providing of funds and all that data plans. And also that some of the things beyond essential as well had offered in a recent MDA. We were having issue because we were coming to the end of close fiscal year, but we were happy that Beyond Essential were able to go beyond and assist the program in providing some of the data that was needed for us to roll it out in the Eastern Division. So thank you, Beyond Essential, for making this happen in terms of our database. Other than that, thank you all.